Hello, everyone. Good evening, good afternoon, good morning, depending on whichever part of the globe you are in now. A great pleasure in welcoming you once again. Today, we continue to learn from the legends jointly with the Neonatal Expert Talks, or next series by National Neonatology Forum India. Thank you so much for joining us. I have great pleasure to introduce the moderators for today, Dr. Somashri Rai, consultant neonatologist from Kolkata, India, and Dr. Raghavendra Prasad, consultant neonatologist from Mangalore, Karnataka, India. Hearty welcome, both of you. Now, friends, let's have a dialogue on the state of the art in neonatal seizures between two legends, Professor Ronit Pressler and Dr. K.P. Vinayan. Professor Pressler is consultant in clinical neurophysiology at Great Ormond Street Hospital for Children at Cambridge University Hospital. She is also associate professor at the UCL Institute of Child Health. Her research interests are vast. In fact, to be honest, if I read the bio sketch of both the legends today, then I'll be taking another 10-15 minutes. So I made a précis of that. Her research interests include neonatal seizures, particularly their diagnosis and treatment. She has chaired a number of international task forces and working groups on neonatal EEG and neonatal seizures, including the ILAE Neonatal Seizure Classification Task Force and the ILAE Neonatal Guidelines Task Force, something that we are going to hear from them today. Welcome, Ronit. It's a huge honor to have you with us. We also have another doyen in this field, Professor K.P. Vinayan. Professor Vinayan is the head of the Division of Pediatric Neurology at Amrita Institute of Medical Sciences, Kochi, Kerala, India. He is an active member of the Indian Epilepsy Society for the past 18 years, ever since he finished his residency training in neurology from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, Kerala, India. He was instrumental in bringing the ILAE Neonatal EEG course from Cambridge to the Asia Oceania in 2020. Ever since then, all the courses conducted by him were hugely popular and had students from most of the countries in the Asia Oceania region, in addition to students from Middle East, Eastern Europe, Africa, etc. Vinayan is currently one of the core members of ILAE Diagnostic Methods Commission and contributes to the task forces for neonatal seizures, EEG, research advocacy, and pediatric epilepsy severity. He is also a member of the writing group of Modifying Epilepsy Glossary and is a co-author of ILAE position paper on classification of neonatal seizures and epilepsies published this year. Hearty welcome, dear Vinayan.
Thank you, Manoj.
So with this brief intro, let me welcome both the legends to deliberate, or rather begin your dialogue.
Okay, thank you, Manoj. I will take the stage first. And it is my pleasure to be here on this forum on NNF India and to introduce my co-speaker or colleague who has been a close friend for the last several years. Ronit, better will be to start with a kind of your journey through the neonatal neurology and the neonatal seizures, because I saw you talking on this topic way back, probably 15 years back, when I think I remember it was in London International, the European Epilepsy Congress, where you were deliberating on this, and then the NEMO trial, I think. So I think it will be good to start with your journey through this as a pediatrician in Germany, and then to England, across the English Channel, and then into neonatal neurology, and then the electrophysiology. How will you look at that, looking back the story?
Okay, thank you very much, Vinayan. And absolutely, thank you very much for inviting me to participate at this fantastic webinar. It's a real honor, so I'm really looking forward to it. So yeah, Vinayan and I have been working together for a long time. And how did I start working in neonatal seizures? Really, this is now, it's, God, 25 years ago.
The lost count of years.
I shouldn't really say. Basically, I started my medical training as a registrar, as an SHO and registrar in Germany in pediatrics in Berlin. And then I went to London to do my PhD with Professor Colin Binney at King's College. And there was another PhD student who is now also a close friend of mine, Geraldine Boylan, who's now back at Cork. And she did her PhD on neonatal seizures while I did mine in pediatric epilepsy. And we, so because nobody else was really interested in pediatrics and neonatal, and I had my training in neonatal intensive care, I started working with her. And so we became close friends, but we also started working together on neonatal seizures and have done so ever since. It was also the beginning of the NEMO trial, which you already mentioned, Vinayan. So then when Geraldine went back to Cork and I became consultant at GOSH, we started the NEMO trial, which was an EU-funded trial on bumetanide in for the treatment of neonatal seizures. And then we did a number of other studies together, and Geraldine obviously now has a fantastic research team in Cork and is publishing so many papers and so many important research results. And I'm at Great Ormond Street now, also at Cambridge and the Institute of Child Health. So it's a long journey, but it's been very good. And I've been
your special expertise in a rare blend of electrophysiology or clinical neurophysiology with the neonatology. That is a very rare combination, I'll say. And you have blended that very well. And looking back on this story, you feel like the neonatal seizures, when you started off, and the way we look at neonatal seizures, it has changed a lot, or it's the same at this point?
I think it has changed a lot because people are much more aware where the problems are and what the challenges are. And people are looking at neonatal seizures far more. In the past, people said, oh, we can't really see them, we can't really diagnose them, we can't really treat them, so we forget about them. We shouldn't really look at them. But that has changed with many papers showing that seizures are associated with poor outcome, and they can actually be diagnosed if you use the right methods. And if you are aware of the diagnostic tools you're using and what kind of diagnostic certainties you have with those. So I think it has changed a lot. And treatments has also changed. Not so much what we use, but how certain we are that it's the right thing to do, I think. Don't you agree, Vinayan?
Yeah, so that is one thing. See, if you look at the history of the classification of seizures, the LA classification of seizures, and even the original classification, neonatal seizures were not very sure where to classify and how to classify, and it was not given as a special category. But now we know that the same principles of epileptology can be applied to neonatal seizures. And then we can take it forward from a pure epilepsy angle. That is one thing which conceptually I look at as an epileptologist with a training as a core pediatrician first, and then a neurologist, then a general neurologist who was working with all sorts of general neurology, and then ending up with an epileptology, finally coming back to pediatric epilepsy and neurology, and then ending up in or more interest in neonatal neurology and epilepsy. What I feel like the issue was people were afraid to come to neonatology and then apply the same principles of epileptology and neurology into neonatology field. So, Ronit, can you explain? See, the neonatal seizures, if you look at it, it looks like a homogeneous pack, but actually it is not that. So how can we look at the classification from an etiology point of view? So that will be the first point I'll like to ask you.
Okay. I mean, I could, if you want, I can show.
Professor Ronit, sorry to interrupt you. Actually, there is a comment in the chat box saying your sound is too low. If you could be near the mic or increase the volume or something, if at all possible. I am able to hear. I just saw a comment. That's why. Yeah.
Okay. Can you hear me better now?
Better, much better.
Okay. Sorry about that. Yeah, I can show some slides talking about the etiology. I agree. I mean, neonatal seizures are, let me show you some slides. 1 second. So I think I absolutely agree with you, Vinayan. Neonatal seizures, looking at the etiology is really important. For the diagnosis, but also for the management, there's no question. And it also has implications on outcome. So neonatal seizures are very common. They are the most common neurological complication or manifestation. Maybe 2 to 3 per 1,000 live births in term babies, more common in preterm babies. And most of these seizures are acute symptomatic or acute provoked seizures. So they're not, as you said, part of an epilepsy syndrome, but they are acute response to a brain injury or brain insult. And in term babies, this is most commonly due to hypoxic ischemic encephalopathy. Other important etiologies are vascular, so infarctions, hemorrhage, or infections. And far less common are brain malformations, genetic and metabolic. And these last 3 etiologies, so inborn errors of metabolism, genetic and brain malformations, are actually often a cause for epilepsy rather than acute symptomatic seizures. There's one difference between high-income countries and low and middle-income countries, and that's the metabolic. The acute metabolic etiologies are not so common anymore in high-income countries, where in low and middle-income countries, you can see it's quite common, 20% here, which is electrolytes, glucose, all of these acute metabolic etiologies. And there has been a recent paper which has been mentioned earlier today. That's the ILA classification of definitions in epilepsy syndromes, which was published earlier this year. And in this, all the epilepsy syndromes with onset in infants and neonates and infants are also described. So we have a much better idea now what syndromes we can look at, or what syndromes they are, and so the diagnosis has become much easier. Yeah, I think sort of those are the most important etiologies.
Yeah, so you to make it clearer for the neonatology audience. So what we are discussing is epilepsy there is an enduring predisposition to have further and further seizures. So that means the brain is having an inherent tendency due to a genetic problem or an acquired thing, or it might be a combination of the two. But here in neonatal seizures, it's most of the things are due to an acute insult. So the question here is, Ronit, then the issue is more the overall everything depends on the etiology. You know? So mainly it will be the outcome will be dependent on the etiology. Is it
Absolutely.
so?
Absolutely. I think the etiology, I agree. The etiology is very important for outcome, but it's not the only thing. There are now papers showing that independent of etiology, the seizure burden, how many seizures a baby has, also affects outcome. So yes, HIE itself is associated with poor outcome depending on the severity, but if you have status epilepticus or frequent seizures, then that itself can make outcome worse. So it's both, I think.
Okay, so the point here is, it is something like, again, a neurological point of view is you have the degree of injury and the degree of ongoing injury and the underlying etiology, both. So within a given etiology, probably the underlying or the degree of ongoing injury will add to the problem. So in a given hypoxic ischemic encephalopathy, if you have a higher seizure burden versus a lower seizure burden, but you can't compare two different etiologies, that might be a problem, Ronit. That will be one limitations when we look at the neonatal seizures. What do you think? When you club everything together and then look at the outcomes, look at the etiology, also look at the treatment effect, everything.
Yeah, absolutely. I mean, there are a few studies, and usually if you look at outcome, you have to differentiate the different etiologies. I absolutely agree. The other thing which is important if you talk about acute symptomatic versus epilepsy, and that's something we're going to talk about later, is how long we treat, because obviously epilepsy you have to treat for a longer period, whereas if you have acute symptomatic seizures, then the seizures stop after a few days, and then you should stop treatment as well. You don't need to continue treatment, whereas if a baby has epilepsy, of course you have to treat, you have to continue treatment for at least the first year of life. So it's very different.
Yeah.
And the etiology is so important.
Yeah, so the etiology is very important. So that is one thing, one message from this dialogue at this point, because etiology gives you a kind of prognostication and which way we should work and which way we should counsel the family. Everything depends on the etiology, but within the given etiology, ongoing seizures, if you are diagnosing and treating an ongoing seizure or continuing seizure burden, will be a major prognostic factor. So that takes us to the next level of our discussion. See, when we all started I still remember in our, I think many of my fellows are here or residents who are hearing this. I always tell the story of the neonatal ICU in my medical school or during my residency, where the final answer is the professor says it's a seizure or not. So there will be always some person say this is looking like a seizure, the other person say it's not looking like a seizure, and then finally that professor comes and says, okay, this is a seizure. So then it's a seizure. So that was the final biomarker. So what do you think about this approach? So we can have a poll at this point, no? So the diagnosis of neonatal seizure, that first question you can...
Yeah, I'll show the, hold on, let me show the first question. So I think this is very similar to what we had when I trained. That was also how it was done. The professor says yes or no, but it has changed now. So here are the first question for the
So the audience, you can, it's a poll time, no, Manoj? You can do the poll.
Yes, it's launched already. I hope you can see the poll. People have started answering as well.
Yeah, the question is really, how do you diagnose seizures most of the time? Clinically, using AEG, using conventional EEG, or video EEG?
it's a little confusing also the question, because some people will be using both, okay, clinical sense and also an EEG. But anyway, we'll wait for the results.
Well, say what you usually use, or most of the time.
Yeah.
So I think 65% of the people are answered. So shall I project?
Yes, that's okay.
Mm-hmm. Interesting. Very interesting.
Yeah, so that's a good thing. So I expected a higher number will be the clinically, but here there is at least 13% using video EEG, 8% using conventional EEG, and there is 14% amplitude integrated EEG. So Ronit, one issue in our day-to-day practice is many times people use an EEG, that is an interictal EEG. You have an event, and then people use it for half an hour or 1 hour, and then try to get a kind of projection into their diagnosis. So what will you see, what is your take on that? So you have an event, suspicious event, and then you have done an interictal EEG.
Yeah, I think that's quite difficult because I agree. If you use, if you look at older children or adults, then you don't need to capture events. Normally, you either have purely a clinical diagnosis, you take a history and make your diagnosis like that, so purely historical, or you use an intake EEG and find an abnormality, an intake abnormality, and you can make your diagnosis with that. But actually, in neonates, that's very difficult and usually doesn't work at all, because one is that clinical diagnosis is very difficult, and I'll show you a few examples in a minute. But also the interictal EEG looks different. We know that even normal neonates have sharp waves or even spikes, and that's a normal phenomenon. And you can't use the presence of spikes or sharp waves to make a diagnosis because it's a normal phenomenon. You really need to capture seizures, electrographic seizures or electroclinical seizures to make a diagnosis. So if you have only an interictal EEG, that doesn't really help you. And I think I agree with you. Often people use the interictal EEG, even you shouldn't, and overdiagnose seizures because they see a few sharp transients, which is, as I said, a normal phenomenon.
Yeah, so that is one message again. So if you see a few spikes in a suspected event, doesn't mean that it's a seizure. It might be a seizure or it may not be a seizure. So the usage of what we call an interictal EEG is a kind of an interval EEG for the neonatologists. I'm just trying to make it simpler. So the EEG, which is without an event, if you take an EEG, it is what we call the interictal EEG, which we usually use in all other age groups for diagnosis of epilepsy. But here the problem in newborn, as Ronit has clearly mentioned, that sharp waves and then the so-called normal variants will make it very, very difficult to positively say that it is an event or it's not an event based on a surrogate marker of an interictal EEG or the EEG markers of spikes or sharp waves. So, Ronit, we can go to the difficulties in the diagnosis, clinical diagnosis now, and how best we can use the clinical semiology to positively diagnose seizures in neonates.
Okay, thank you. So, as we discussed, you can diagnose seizures by clinical observation using AEG or full EEG. And so the question about the clinical diagnosis, I mean, as you saw earlier, 2/3 of all people attending this webinar using mostly clinical diagnosis. And there's a brilliant paper by Geraldine Boylan's group, And what they did is they had 20 video clips. 9 of them were non-seizure event and 11 were seizure events. And they sent this to 130 healthcare providers or consultants, mostly neonatologists. And all of them were specialists in neonatal neurology. So they should be the best people to diagnose seizures clinically. So they were sent these video clips, and all they had to do is say whether a video clip was a seizure, yes or no. And I've got 2 of those original video clips here. And I thought I'll show them to you, and you decide for yourself whether something is a seizure, whether these are seizures or not. So this is the first video clip here. And you see a neonate, and you see this movements here in the arm and then the legs. Do you think it's a seizure? Yes or no? Okay. And here's another baby. Here, baby in an incubator. Here's the mouth. Look at the mouth. Baby's sucking a bit. Here, a bit of mouthing. Is it a seizure? Yes or no? Would you treat? Yes or no? So what is the answer? This one, the first one, it's not a seizure. It's a baby with mild HIE who is a bit jittery, but that's just jitteriness. So the EEG shows there are no seizures whatsoever. And the second baby with the mouthing, you can see that there's a seizure here. And all this shows is that really you need a confirmation with EEG or AEG if you're looking at clinical events. The other problem is that many seizures, maybe even 50% of seizures, are electrographic only, subclinical. So you don't even see any manifestation, and the babies have seizures. Without EEG, you would never be able to diagnose them. And the most difficult bit is that most babies who are in status epilepticus are electrographic only, so they have no clinical manifestations if they're in status. Again, that means that without EEG or AEG, you would not be able to diagnose them.
So that means there is a kind of overdiagnosis and the underdiagnosis at the same time. Mm-hmm. So it means you overestimate some of the events, and then it will be colored by the history you are getting. So it is something like the same moment we may call, the same observer may call it as a seizure if they say that the child has got a hypoxic ischemic encephalopathy or some kind of a distress during the neonatal period, and then there is a chance for overdiagnosis. And electrographic seizures, mostly we can't diagnose it without any EEG, and that is very, very common in the HIE group, especially the stage 3, the Sonat stage 3 is HIE, where you will have a whole lot of neonatal, the electrographic seizures in the first 24 hours itself. So that's the message you are trying to say, no? Ronit?
Absolutely. I couldn't have, yeah, very well put, absolutely. And then...
so where will you place this amplitude integrated EEG now?
So the amplitude integrated EEG is, I mean, obviously full EEG is something that not many units have access to. I mean, even if you're looking at the UK or other European countries, most units don't have access 24/7 for full EEG. There's a really, I mean, we did a survey in the UK. There were only like 5% of neonatal units who had access to full EEG 24/7. And that's obviously not a good situation. So the use of AEG is, AEG is widely used in many parts of Europe, but not in so many countries, in low and middle income countries. I think it's very helpful, but it has limitations. So I think as long as people are aware of the limitations, it's very good.
Okay, so you are an electrophysiologist per se, no? So what you would like to say, what way you are seeing? The main problem is even in our setting, say now the many government hospitals, the public hospitals, there is a specific funding coming up to improve the neonatal care. And then there is a lot of money has been put on neonatal brain salvaging in India. So now there is special program. So then the neonatal, the EEG machines are getting into the NICU. But the real question is, as Manoj once he was talking, he puts it as who will monitor that monitors. So that is the real issue here. See, even a trained neonatologist or a trained neurologist finds it difficult to identify some seizures as seizures. So which way we can take it forward, because it's not that easy to do this.
Absolutely, I fully agree. I mean, I think, so I'm part of the PREVENT trial, which runs in India. And so we have built up neonatal EEG in 3 public hospitals over the last few years, and it worked brilliantly. I mean, the quality of EEG has been fantastic. They've really managed to build up very good EEG. But as you said, that took a lot of training, and we had weekly reporting sessions. We looked at EEGs, and there was a lot of hand-on training and continuous training throughout this study, and that is what is needed. I think both EEG and AEG can be difficult to do if you don't have the expertise. And so training is so crucial, but it can be done. And the good thing nowadays with modern technology, you can do both AEG and EEG at the same time, and you can do virtual supervision and virtual reporting via the internet, and that has been very helpful.
Okay, so the importance of training the technicians and the nurses and the neonatologists and the fellows is the most important thing if we want to take it forward. And we might need more and more sessions like this, or the hardcore neonatal EEG sessions, where we have to discuss this and then train the different aspects, because it's not that simple like an ECG. Mm-hmm. So the point here is, you feel like the technology will help us in the near future, something like an automated seizure detection things in the neonatal ICUs.
I think yes. I mean, I think the to a certain degree. I mean, I think if you use AEG and there are automatic seizure detection programs for EEG and for AEG, and they can all be very helpful. But at the moment, the technology is not quite there yet. I mean, hopefully maybe in 10 years, but at the moment, even with automatic seizure detection, there is a problem with the artifact, and you have lots of artifact on the ITU, and you have the problem that short seizures or low amplitude seizures will be missed, similar to an AEG. So I think we're not quite there yet, but maybe in a few years.
Okay, so that will be too technical, but as an clinical neurophysiologist, if you are hopeful of a good outcome, but we were expecting, actually last 20 years of my training, I'm hearing this automated detection, but we are not there yet. It's a kind of a holy grail so far, but probably we will reach it. And it is not only for neonatal EEG, it's ICU EEG, all trending softwares. But see, the newer things is the newer softwares, the trending softwares and all those things have helped us to review this much better.
Absolutely. I mean, I think with trending, that has really made a difference. And I use trending now all the time together with my EEG. And I think that really makes a huge difference. But again, it's more technology and again, more training needed. But I fully agree. It's so important.
Yeah, so hopefully the technology becomes cheaper, and that's happening in India. And at this point, neonatal EEG, I think in the next few years, almost all good NICUs will have an EEG machine, probably more than one or more than two. But till we reach there, what can we do with the neonatal seizures now, the diagnosis of neonatal seizures, the diagnostic accuracy of neonatal seizures, because that's one issue everywhere when we put that our classification scheme out in the wherever we went, wherever we discussed. You also might have had a lot of experience saying that even though you say that EEG is the gold standard, conventional EEG is gold standard, but we don't have it. So what will you do now? And can we will not diagnose neonatal seizures, or we will wait for the EEG to come?
No, absolutely. I think that's a very important question. So this is why we included the diagnostic certainties into the classification. So the Brighton collaboration did a case definition for that was published in Vaccine a few years ago. And as part of their case definition, they always have the diagnostic certainties. So how certain are we that we can diagnose something? So here, this is the diagnostic certainties for neonatal seizures. And what we said is that here you see continuous EEG or conventional EEG is the gold standard. If you have a baby with an event and there's an EEG change in this, then you have a definite seizure, so gold standard. And you can also exclude seizures. If you only have a EEG, then this is a level 2, a probable seizure, because if the seizures are short or low amplitude, or you have your electrodes over a different region, then you might miss the seizures. And you have a high risk of artifacts looking similar to seizures. So it's a probable seizures, and you cannot exclude seizures because of the reasons I just said. But you have a level 2A, it's a probable seizure. If you have no EEG or AEG, which can happen obviously, then you are relying on an observer, an experienced observer. And then only focal clonic and focal tonic seizures can be diagnosed. So here's an example of a focal clonic seizure. You can see the clonic movements, a regular jerking, repetitive, regular jerking of one limb or two limbs, but it's focal, not generalized, or a focal tonic seizure. Here's an asymmetric tonic posturing of the right arm in this baby. Those two seizure types you can diagnose with probable diagnostic certainty, but all the other seizure types not. For all the other seizure types, you really need EEG to confirm, specifically for automatisms like the mouthing, because most mouthing events or oral automatisms are not seizures, only very rarely they are. So yeah, I think obviously if you have EEG, you have level, you have oops, sorry, you have a level 1, level 2A is for AEG, and then probable seizures. 2B is for focal clonic and focal tonic seizures. Do you want me to go straight to the classification, just because I'm talking about the seizure types here?
Yeah. That is better. See, the real question now is other question. Usually the neurologists ask, say, I don't know, the neonatologist may not be that much interested, but if it is an acute symptomatic seizure and you are worried about the etiology, whether there is a need for it, something like a hypoglycemic seizure or a hypocalcemic seizure, whether it's a tonic seizure or a clonic seizure, doesn't make much sense. But and then we say that neonatal seizures are mostly acute symptomatic seizures. So that is a real question, whether we have to take this classification of epileptic seizures into neonatology. And then probably you might have had a lot of discussions in the group, and how you finally reach this conclusion, and what is your conclusion when you are thinking about neonatal seizures, how to classify the neonatal seizures now?
Yes, I agree. It's most neonatologists don't really classify seizures. They just say it's a neonatal seizure rather than really classifying it. But as you know, as an epileptologist, it's really important to have, to make a proper diagnosis, to classify. First of all, it improves the multidisciplinary approach. So if you have neonatal seizures, lots of different specialities will work together on those neonatal seizures, on these seizures. So you have the neonatologist, the neurologist, the neurophysiologist, the geneticist, the metabolic team, all different teams. And so if you have a common language, you can work much better together. And the other thing is that the seizure type also gives you an indication what the etiology is. So depending what seizure type the baby has, that will help you to identify the etiology. And we have worked, so the International League Against Epilepsy has initiated this task force, and we looked at lots of different ways how to classify, and we came up with this classification. So where we start with a critical ill baby or with clinical suspicion, and then this is confirmed with EEG or AEG. So if there is no correlate, then we ignore those. Those are not, we don't consider them as seizures. If you have a correlate, then those seizures are classified according to whether they have clinical signs or no clinical signs. So no clinical signs, electrographic only. And if you have clinical signs, they're classified exactly the same way as seizures in older children, but we have a much smaller number of seizure types. We really only have these seizure types, so motor, non-motor, sequential, and unclassified. And the motor seizures are automatisms, focal clonic, spasms, myoclonic and tonic, focal clonic, tonic seizures, and non-motor are autonomic seizures and behavioral arrest. And then we have sequential seizures where you have a sequence of different manifestations. And really what other people also showed, there are quite a few publications now about this, is that if you have focal clonic seizures, that's very typical for stroke or hemorrhage. Whereas if you have spasms, that's typical for inborn errors of metabolism, myoclonic seizures also, while you have tonic seizures and sequential seizures, which are typical for genetic epilepsies and channelopathies as a subgroup. So I think classifying the seizures, looking at the semiology and making a judgment of what kind of seizure type it is can be really helpful in the clinical management of those seizures.
Yeah, I agree. So basically the thing is, we have not looked at this in that way previously. Probably we have missed that semiological features earlier, and then we are clubbing together. And the more you look at that, say that previously we started with the focal clonic is always pathology, vascular, but I think we now say that it should be persistently lateralized clonic seizures. Otherwise, the clonic seizures can occur in infections also. So so it should be a kind of consistently one side focal clonic seizure, mostly suggest a vascular, but if it is coming from both sides, mostly it can be some kind of infections also. Mm-hmm. In our setting, especially in our setting, I have seen more infections coming like that, rather than it will switch. It is not one seizure. One seizure will be one side focal clonic, but the next seizure will be the other side clonic. So it will be like flowing from one side to another. So anyway, so we have almost reached almost 40 or around 70% of our time we have completed. So we have to go to the management side. We can show that 2 slides which we would like to project now to get a kind of audience response for the best management options in neonatal seizures, or what they are currently using.
Okay, so do I show this? Yeah, these are the questions. So the first question is, what is your first line anti-seizure medication for treating neonatal seizures? Phenobarbital.
So this is not the ideal thing, what you are using in your practice. It's not the textbook which we want to know. So what you are using now at this point.
So you can go to the poll and say what you're using. Absolutely. Actually,
Manoj, the poll is on, no?
the poll is on, yeah, I think.
You are muted.
Are you not able to see? It is
Yes,
on.
yes, they are able to see.
Okay. I think a minute has passed. I think we'll share the results.
So 82% phenobarbital. Okay, so that's, and 13% levetiracetam. Okay, so we'll go to the next question. You can show the slide. No, we have to share the slide, Manoj, or you can show that question.
Go straight to the poll.
Yeah, you can go straight to the poll. No.
Right. I hope you're able to see.
Yes.
So this is the second line anti-epileptic drug once the first line has failed. You can show it now.
Yeah. Okay.
Okay.
Interesting.
Okay, again, as expected, now the levetiracetam is coming in a big way in the second line. Okay, so this is one of the issues, no? So Ronit, when we are coming to the management of neonatal seizures, nothing has changed over the last, the first line remains the same old phenobarbital. Probably our teachers were using it, our professors were using it when they were residents. And now we are almost 50 years, 60 years history of using phenobarbital. So why this, there are a lot of anti-epileptic drugs have come into the market and nothing has reached the neonatal practice. Why this issue? So what is the primary issue of the new drugs not coming into neonatology?
Well, I think it's I absolutely agree. I mean, it's astonishing that if you look at how many drugs we have for older children and adults, how little we have for neonates, even though seizures are so common. And one problem is that we don't have enough randomized controlled studies. And that has a number of reasons. One, it's really difficult to do those studies because you need full EEG and you need lots of neonatal units to take and consultants to take part. It's really expensive because you need to do the EEG. Clinical diagnosis doesn't work, as we discussed. You need all the expertise. But it's also really stressful for the parents. I mean, if you think you have parents who think they are going into the labor ward and they have come out with a healthy baby, and suddenly their baby is on an intensive care unit and is critically ill with lots of cables and everything, and then they ask whether they want to take part in a clinical trial. That's really worrying, and many parents don't want to take part, and they say they don't want their babies to be guinea pigs for research, and it is very difficult. Plus, you don't really have, the doctors don't have time to ask for permission. If you have an epilepsy study where a drug trial for epilepsy, then you give them the leaflet and say, you look at this, you come back in 4 weeks, and then we can discuss whether you take part in this trial. On the NICU, the parents have an hour or half an hour to make a decision. And that's very stressful. And it's also stressful for staff. They need to find the time to discuss it rather than just treat. So for all of these reasons, we have very, very few good studies. And and that explains why we still use phenobarbital. That's only part of the story. I think phenobarbital actually works, and everything what we have tested so far hasn't really worked as well. And that's the other part of the story.
So that's a first-hand experience. I think the NEMO trial, you were one of the lead authors for that, and then you worked very hard. And then the randomization, it was a premature termination of that trial. You know? So because of one is lack of enough people and also some perceived side effects.
Well, but the NEMO trial wasn't actually a randomized control trial. It was a combined dose finding efficacy study. But yeah, it was really difficult to get enough patients, and we stopped after a year. We only had recruited 14 patients. That's not much at all. I mean, if you look at other trials, you can't really go on with that. But the main reason why we stopped is because we had side effects. So we stopped, but I don't know how long we would have been able to continue and recruit all the patients we would have needed. I agree, it's really hard.
Yeah, so that is generally we can say the pediatric trials are difficult and ethically more difficult, and the more and more you deal with young infants and neonates, it's much more difficult to get the consent and get the randomization. So that takes us to the next thing is immediately then the application of data, or when we are looking at the guidelines or developing guidelines or a consensus recommendation. If you don't have good data, then we may not be able to reach good conclusions. So that's the problem in newborn period now, and the neonatal seizures especially. And can you elaborate on that, because we have just completed guideline an updation of the guidelines from the ILAE, and it has just been submitted to Epilepsia after the mandatory comments through the ILAE website. So you can, Ronit, you can just elaborate on what we did over those years. You are the prime force for the last 10 or more than 10 years you are working on this.
So thank you. Yeah, you know how much work it was, because you have been really working on this as well, and were a major part of this. So here, this is the ILAE has, I think it was not as long as this, these guidelines we have been working on maybe 4 years, something like that. There were the guidelines before, which were published in
No, I think this was at least 2 terms, Ronit, because it's 8 years, almost 8 years now, because this started with the previous task force, and then it has continued.
It was sort of in the middle of the previous one, and now we've, I think it was 5 years or so. I think so.
More than that, around that.
So what we did was we did a systematic review and guidelines according to the ILAE guidelines for guidelines. So we had, and these are here, shows you the how you develop guidelines. So we followed all those steps. We had an international multidisciplinary working group. So we have neonatologists, neurologists, neurophysiologists, methodologists, and then we formulated priority questions. And that's really the key questions we wanted to answer was, what do you use first line, second line? When should you stop anti-seizure medication? What is the effect of therapeutic hypothermia? Should you treat electrographic seizures? And then how important is, or how safe is it to use pyridoxine, pyridoxal 5-phosphate? And then we looked at the evidence, and we had, here you can see how many papers we looked at. Over 3,000 papers. We screened nearly 4,000 papers, and then looked at over 500 in more detail. And so the basic, I'm only showing you the main results, or the key recommendations. the whole of the recommendations, the first proposal was is still on the website. So if you're interested, you can look at it. And as Vinayan said, we just submitted last week the final version, which takes into account the public consolidation, public comments. And so hopefully in the next 2-3 months, it will be published as well. But basically, first-line medication, we looked at all the evidence and we said, we found enough evidence to recommend phenobarbital should be first line. There is evidence now, and the main study is the study by Hearty, which is a randomized controlled study comparing phenobarbital with phenytoin. And that should be used regardless of etiology. So in any etiology, first-line medication should be phenobarbital. The only exception is if you have a family history of a channelopathy, so KCNQ2, but only if there's a family history. And second line, and that's interesting because when you looked at the poll we just saw, there was really quite a variability, and this is what we found as well. First of all, there was no evidence whatsoever which drug is best. So we looked at phenytoin, levetiracetam, midazolam, lidocaine, and there is no evidence from randomized controlled trials. And then we did Delphi and asked all the experts in the group, and we couldn't find any agreement, no agreement whatsoever. All we could say is you use one of those drugs, but which one is best, we can't say. Again, only if there's channelopathy from suspected because of EEG or clinical manifest features, then you should use phenytoin or carbamazepine sodium channel blockers. The only other thing is if you have a baby with cardiac disorder, levetiracetam is better because phenytoin and lidocaine are cardiotoxic and they're not advisable. But not, this is a recommendation based on Delphi, not because of evidence. And the final one I just want to mention here is the when to stop anti-seizure medication. And again, there was no evidence from papers. So we said, we did a Delphi, and what we found is what we all agreed with a high level of agreement was that if seizures respond to treatment and are considered acute symptomatic without the evidence for neonatal epilepsy, then the medication should be discharged before the baby's discharged home, regardless of MRI or EEG findings. I'm not sure, Vinayan, is this what most people do in India? Or...
Yeah, the stopping of anti-epileptic drugs you're asking?
Mm-hmm.
Yeah, now see, that is probably the neonatologists are more and more comfortable. I think we are also learning. See, the thing is here, anti-epileptic drugs, we have a tendency to taper it off because of our experience in other age groups. Usually we never stop it suddenly. But I think there is not much recurrences are there, and even if the recurrence is there, it is not going to be prevented by this treatment. At this point, I think if you look at the side effect profile of the original drugs, it is better to stop. That's what we are also following, and most of the ICUs are now moving in that direction. So probably we can have a discussion during the last part of this, the Q&A sessions and the comments. So there are a lot of issues, no? See, when it comes to the concepts and even the EEG and the technological part of it has evolved significantly. But when it comes to the management part of neonatal seizures, still, I think there are a whole lot of questions here. What are our short-term goals, or what are our goals of treatment in any case of neonatal seizures? Are we actually suppressing the neonatal seizures is the best goal, or we should look at the neurodevelopmental outcome, long-term seizure outcome? So, or either we should have all these things. So what should be your take? Because which way it should, this is the future research of all these things. We want a good baby to survive with a good brain. So only suppression, short-term suppression of the neonatal seizures should be the goal, or it should be the long-term goal, which is actually dependent on a lot of n number of factors which we don't know.
Yeah, no, I couldn't agree more, Vinayan. I think that's exactly it. You need to look at both. I think you need to look at what a drug does to the seizure burden, so the acute outcome, but you also need that long-term outcome, and you need to look at the developmental outcome at 1.5 years or so. How many of these, what is the developmental score? What is the neurological deficits like blindness or deafness, but also whether the babies develop epilepsy or not. So all these factors have to be evaluated. But again, that makes the studies more expensive because you have to...
that will be the real holy grail of neonatal seizures, because this long-term outcome is dependent on so many factors, because it's dependent on the etiology, the degree of injury, and then what happens in between. So this is one of the most difficult part of the story, I think. And hopefully we will have, see, the other problem is, unless we have a very good large number of cohorts, to get that outcome, statistically significant outcome itself, it will be very, very difficult. So I think that is the, but at this point, phenobarbital rules and no other anti-epileptic drug at this point. Currently, the drug trials which have come out also shows that phenobarbital efficacy-wise is a better drug. But long-term safety issues are still there. No, Ronit, you will discount that?
Sorry, if you...
The safety issues, the long-term safety issues of phenobarbital.
I think phenobarbital has safety issues, but I think we have more evidence for acute rather than for long-term. There are animal studies and also clinical studies suggesting that there might be a long-term effect, but these are very different to what we do in clinical practice. I mean, the clinical studies have babies who have been treated for a year or two with phenobarbital, and that's not what we do, or who have been treated in intrauterine during pregnancy. And again, that's not what we do. So you can't really use those data. There's no animal model which shows that a couple of days of phenobarbital definitely has an effect on outcome. But who knows? We need those studies. I think phenobarbital has an effect on respiration and can prolong stay in the hospital. So we should only use phenobarbital if a baby has really seizures. So you need to be sure you're treating seizures and not some other movements before you give it, but it is the most effective drug. And I think it's, yeah, I think I have not real safety concerns if you use phenobarbital for a few days.
Okay, so that way we can conclude that at this point, so the efficacy point of view, phenobarbital rules, and the safety aspects for a short-term exposure, we don't have that much evidence to show that it is really bad, but we don't know. So, but anything which you can take home from this discussion is, whenever you have a child with suspected seizures, use the first-line drug. And then when you have a suspected, especially when you don't have a child with a family history of neonatal seizures, then use a sodium channel blocker like phenytoin or carbamazepine as the first line, or some countries use oxcarbazepine also nowadays. And then don't forget the vitamin responsive epilepsies. When things are not going well, always try a dose of pyridoxine. And with that, I think we can, there are a lot of uncertainties, and probably if we have 4 years or 5 years down the line, if we have a dialogue like this, probably we would have moved forward, because we have now a classification scheme. We are looking at the patterns better now, and we are not lumping all the neonatal seizures together as one, and then trying to have a single approach to all the drugs. probably over years, we will be able to find out better patterns, clinical patterns of neonatal seizures, better semiological diagnosis of neonatal seizures, and then targeted treatment based on probably the clinical semiology, EEG, and also the rapid genomics. Maybe we can discuss that also. So what about rapid genomics into neonatology, where you will add, or will there be a value if you have a rapid turnaround time of genetic testing?
I think yes, but so I think the clinical manifestation and the EEG can be really helpful. And I don't think it's necessary to do genetic testing in all babies. But I think if you have no clear diagnosis, also not, and you have babies with tonic seizures or sequential seizures, then you should do genetics. And obviously, the quicker you get the results, the better it is.
Okay, so the moral of the story is there are some clinical seizures, like the sequential prolonged seizures in children with multiple flowing manifestations without a clear insult. So there is nothing, a sentinel event is not there, and the child comes with a significant encephalopathy and a very prolonged seizures, very resistant to anti-epileptic drugs. These are the babies where you have to think of a genetic disorder and then try testing, and also try the sodium channel drugs as the first line, because many of these channelopathies respond to sodium channel drugs. So with this, thank you, Ronit. It was wonderful to talk to you, and it is always, we talk otherwise also, but online in front of this large audience, it was always a wonderful experience. And I think the people who have joined from different parts of the world got something from this dialogue. And over to the organizers, NNF and Manoj. And thank you, Manoj, for inviting us here.
Thank you. But please hold on. There is a volley of questions for both of you. So may I request Dr. Someshri and Rajendra Prasad, are you there, or yeah?
Yes, sir.
Please, let's start with the questions. There are a volley of questions that have been asked. So how much time do both of you have for this to take these questions? 30 minutes is okay?
Yeah, so some of those have been already covered, but
most of them are covered.
Do you want to? Yeah, okay, please go ahead.
So there is a question by Dr. Waji here about the role of interictal EEG. I think we have already discussed about this.
Yeah.
So yeah, I agree. I mean, we discussed this. The interictal EEG can help you sometimes with etiology. So for example, if you have burst suppression pattern, but most of the time you need an ictal EEG rather than an interictal EEG. It's good for the diagnosis, but not for whether a baby has seizures or not.
Yeah, so there is a question on, maybe Ronit, you can take that. So the neonatal epilepsy syndromes be diagnosed or suspected with an amplitude integrated EEG?
So I think that's the same as I just said. So it's AEG is good for diagnosing seizures, but not really for the etiology. There is one AEG pattern which has been described for channelopathies, but most of the times you need an EEG rather than an AEG to help you with the etiology. So epilepsy syndromes are better diagnosed clinically and full EEG rather than AEG, because you want to look whether there's an epileptic encephalopathy or burst suppression pattern. So I would say for epilepsy syndromes, EEG is much, much better than AEG.
There is one more question, like comparison of AEG versus conventional EEG, if it is read by a pediatric neurologist versus a neonatologist, if I correctly understand the question.
So, hold on.
Victoria. Dr. Victoria. Yeah.
So I think the AEG I think the best way is to work together. And that's sort of always what I say. Ideally, you want to have the neonatologist and the neurologist working together closely. And ideally, if you have AEG for the neonatologist and EEG for the neurologist, then you have the best of both worlds. And with modern technology, you can record both at the same time. So we are just doing a study which is called the EAGLET study, where we test exactly this. So we have AEG for the neonatologist and EEG for the neurologist, and we're looking at it at the same time. And hopefully we can show whether this improves the diagnosis.
No, but now most of the new machines are giving both the options, no, at the same time.
Exactly.
Yeah. And then there is a question, if all neonatal seizures have an EEG correlate?
Good question. So in principle, yes. There is this scenario in older patients, in adults, that you can have, or in older children as well, you can have seizures without any EEG correlate. But actually, this is very, very rare, or maybe not even possible in neonates, because the skull is much thinner and the discharges propagate much quicker to the surface. So you can, if you do a very short EEG, maybe not, but if you do a longer EEG, you should always see a correlate. So this is why in the, we are not considering clinical events without an EEG correlate, if you have them, as seizures, because the risk of overtreatment is far, far, far bigger. It's such a rare or maybe impossible occurrence.
Yeah.
So the point here is the so-called old non-epileptic seizures are not actually seizures in the real sense from the point of view. They are all mostly release phenomena of a badly injured brain. Yeah. So that's always that legacy of the Wald classification, and which has been taken into the Mizrahi classification also. So that is actually there in the pediatrics and neonatology thing. So that it will take time, because the basic issue here is all movements are not epileptic seizures.
Mm-hmm. Yeah, and the risk is really, the major risk is to treat everything, because then most of these events are not seizures. Yeah.
Yeah. Then there are several questions on treatment. I think we have already addressed them. Can we start phenobarbital for treatment, then discharge on levetiracetam? Is that okay? What is the efficacy of levetiracetam as second line on first line? I think you can summarize in a short phrase.
So I think I think we all agree that phenobarbital should be first line always. And then whether you add levetiracetam or phenytoin is really, there's no evidence. I can't really recommend anything. The Sharpie study has suggested that levetiracetam is not very useful, but at the end, but it has very few side effects. So it's really, I don't know, it's difficult, but you can use any of those. I just saw another question about other drugs like topiramate. Yes. And I think I would be extremely careful. I would not recommend any drugs which have not been tested in randomized controlled trials in neonates. And topiramate has not been tested. We don't know how safe it is. There are concerns that it causes neck in neonates or in preterm babies. I would be extremely careful. I would never recommend topiramate before it has been tested. And so that's the main issue, that we can recommend those drugs which are in the which we have mentioned in the guidelines, so levetiracetam, phenytoin, midazolam, and lidocaine, because we have safety data in neonates. But in all the other drugs, we don't have safety data. Is there anything else?
There is a question, Ronit, on treating bird. That
Good question. So birds are brief interictal or ictal discharges. So discharges that are shorter than 10 seconds. And I think as a rule, we shouldn't treat birds. You should continue monitoring. So if you have an EEG with birds or with brief runs of discharges, you should continue the monitoring and then decide if you have real seizures, which are longer than 10 seconds, then start treatment, but not before. So birds are an indication to monitor, but not to treat.
Yeah, so the message is clear. Say, it is just a marker or an indirect marker of an underlying seizure. So try to get the seizure first and then treat it.
And there are a couple of questions on.
Yes.
And there are a couple of questions regarding suspicion of channelopathy or epilepsy syndrome. Is starting from the history and clinical clue, and then typical EEG patterns like that. So the participants asked that when to suspect this in case of refractory seizures, when to suspect channelopathies and epilepsy syndrome.
Vinayan, do you want to?
Yeah, when to suspect channelopathies and say basically which that we have actually discussed. Say the patient is no sentinel events. When you have a family history of neonatal seizures, or it might be a de novo mutation sometimes. So the point here is a bad seizure with an encephalopathy which is not responding to the standard anti-epileptic drug. That is the situation we can think of a channelopathy. And the type of seizure is a sequential seizure and tonic seizures, Ronit, which is mostly associated with this. So when you get both these things, especially sequential seizure, long seizures, then you have to think of channelopathies and then treat with sodium channel blocker, because these drugs have got a specific predilection to control seizures, or it will control the seizures better compared to phenobarbital and levetiracetam.
Yeah, I agree.
And then there is a question of this electroclinical dissociation. That Ronit, your electroclinical dissociation with phenobarbital.
Oh, the uncoupling.
Yeah, uncoupling.
So yeah, I think we see this with phenobarbital and with phenytoin, possibly also with other drugs, but it hasn't been really tested, is that if you give a drug to a baby with electroclinical seizures, the seizures become electrographic only. So it's not really a side effect, because it means it's just how the baby brain, the immature brain, responds to anti-seizure medication. It can suppress clinical manifestation without being effective to stop seizures altogether. And all that means is that you need to monitor. You need to use EEG or AEG to continue monitoring if you use phenytoin or phenobarbital. It makes it a bit more difficult, but on the other hand, you have electrographic seizures in other babies too. If, for example, if you give morphine or any kind of sedation, you have uncoupling as well. And so it's just something you need to be aware of.
No, but is it specific to newborn, Ronit? Because that can be seen in all the ICUs, a bad seizure which is coming and then you are treating. It's just saying that it is not it's a partial control.
Yeah. Well, I'm not even sure it's partial control. It's just that the clinical manifestations are suppressed, but there's no real control. Yeah. But you're absolutely right. I mean, you see this on ITU in adults as well. And in adult ITU, there's also a need to monitor. And yeah, I agree. I mean, it's a intensive care problem rather than a neonatal problem.
Okay.
There is one more question. In case of suspected tuber sclerosis, when the baby may be fulfilling the criteria of having TSC, So will you start vigabatrin or everolimus from the beginning, from the day one itself? So should we start by phenobarbital, or should we start vigabatrin as a drug of choice for seizure, if the baby is throwing seizure?
Yeah, difficult. There is no safety data, so we don't know. I would personally probably start with phenobarbital first.
Mhm.
And then if a baby has spasms, then go to vigabatrin. To be honest, I've seen a few babies with TS who have seizures onset in the neonatal period, but they didn't start with spasms. They developed spasms at 4 weeks. And then you are outside the neonatal period and can do whatever you do in infants. So then the question is not a neonatal one anymore. I haven't really, I mean, maybe 3 weeks, but not before. If you have in the neonatal period babies with TS, they usually have electrographic seizures or other seizure types, and then you would use phenobarbital. Everolimus hasn't been tested in neonates and it's not licensed. You can't use it because there are no safety data.
Yeah, I agree.
I think we have covered most of the questions.
All right, then.
And then one more question is there. What is your, do you advocate treating electrical seizures?
Sorry?
Electrical seizures treatment. Treatment of electrographic seizures.
Oh, treatment of electrographic seizures, yes. Good question. So I don't think because of the uncoupling, I think we should treat, or we should manage electrographic seizures just the same way as we treat electroclinical seizures. I think they are no different because we make them electrographic only in most cases. There have been a couple of studies looking at the treatment of electrographic studies, but none of them, all 3 studies were underpowered and couldn't really answer the question. On the other hand, we have some indirect evidence that if you diagnose seizures early and treat all seizures, including electrographic seizures, then you can reduce the seizure burden effectively, and less babies are discharged with anti-seizure medication. So there is some indirect evidence that if you treat seizures, all seizures, electroclinical and electrographic only, early and effectively, then hopefully the outcome will be better because we are able to reduce the seizure burden, I think.
So thank you so much, Professor Ronit, Professor Vinayan, Dr. Somashri, and Dr. Raghavendra Prasad. Now may I invite Dr. Surendra Singh Bisht. He is the Secretary General of National Neonatology Forum India to propose the vote of thanks.
Manoj, thanks. Thanks, Professor Pressler and Professor Vinayan. It was such a nice, lucid, simple, yet to the point dialogue, very pertinent for us neonatologists. Though we were working in the 2 different worlds as pediatric neurologists and neonatologists, but neonatal seizures are a dilemma where we struggle every day. Today also in the morning rounds, we had this issues about what to be given. Mostly we are still struggling with a lot of HI in public hospitals. And we have discussion, and that is the reason so many of the questions were coming to your way. And on behalf of National Neonatology Forum India, I'm so thankful to both of you, sir and madam, to have done such a wonderful, simple dialogue. And Dr. Manoj, you have a great craft in actually organizing such simple things With a simple pose, simple interactive, everybody feels that they have something to learn from it. And Somushri and Rajendra, very, very good, very good, great of you to have taken out your time from family for this Learn from Legends and NNF Next webinar series. Thank you.
Thank you.
Thank you very much.
Thank you very much.
Thank you all. Now, before we end, I would also like to thank all our distinguished delegates who have been attending this session from for the last 3 years now, from June 2020. Now we are almost reaching the 4th anniversary. So it is like the 3rd anniversary, and then it is a true honor to have you with us all throughout, watching in various platforms. We are not finished with neurology yet. On 4th May, again after 2 weeks, we have Fetal Neurology, Current Landscapes and Path Forward by Dr. Sonika Agarwal. She is Assistant Professor of Neurology and Pediatrics at University of Pennsylvania, USA. So I would invite all of you to join us at the same time on 4th May, Thursday as well. With this, with all your permission, we will close for the day. Thank you so much once again.
Thank you very much indeed.
Thank you.
Thank you.
Thank you all.